2:23. I'm gonna call the October REMAC meeting to order. Just get the notes up real quick. If you haven't had a chance yet, please do sign in. We're gonna start with a salute to the flag. And then I'm gonna ask everybody to please remain standing for a moment of silence as we keep in our thoughts and prayers those U.S. soldiers who are now being sent in harm's way as we enter a war. Those police officers and firefighters and EMS providers that are helping to keep us safe and provide care for us, to keep the peace, and for those of us who we may have recently lost. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you for that moment of silence. I appreciate it. Just as a point of information, when we do have an opportunity for questions, there's a microphone that needs to be passed around that you need to speak into so that people online can listen. According to open meetings law, all public meetings must be held in person. We are webcasting for viewing only. Attendance is not taken from those who are viewing, only from those people who have signed in today. Those members online may not vote, and their attendance does not count towards quorum. I've received excuses for today's meeting from Dr. David Newbert, Dr. Mulbauer, Dr. Keenan, Dr. Gujral, EMT Bruce Cohen, Dr. Rowe, Dr. Harris, and EMT nurse Kevin Mackey. I'll provide to you those excuses after the meeting. I need a motion to approve the minutes as sent out from the August 7th. So moved. Okay, thank you. I have to apologize before I make that motion. There was one correction to the attendance. Dr. Ting was present. She did sign in, but I didn't see her sign in because part of the ink didn't show up on the sign-in sheet, but I saw the impression on the photograph. She reminded me that she was here. So with that correction, Dr. Kirsten, is it okay? Dr. Shearson, okay with that correction? Okay, thank you. Okay, anybody oppose the motion? Anybody abstain? Okay, so keep going. Incoming correspondence. The first thing we have to do is read into the minutes, the Bureau of EMS Compliance Bureau reports in reverse date order from the website. Jay Vincent, EMT 251439 for violation of Part 800.16A6, 800.16A10. EMT card revoked effective 9/10/24. James Wilkinson, EMT 458352 for violation of Part 800.15A, 800.16A2, 800.16A13. Revoked effective 9/4/24. The revocation is stayed pending no further violations during a probationary period of 3 years. Assessed a civil penalty of $6,000, $4,000 of which is stayed pending the same probation period. Louis Carrillo, EMT 272873, surrendered for violations of Part 800.16A10 and 800.3AN. Surrendered effective 8/7/24. Andrew DeWolf, EMT 232204, for I can't even read what I wrote here, for 134 violations of 10 New York Code of Regulations, Part 800.16, revoked effective 8/26/24, and assessed a civil penalty of $26,000. Wow, let's not jump. Yvonne Day, EMT 416186 for violation of part 800.15B1, suspended for 1 year, effective 8/21/24. The suspension is stayed pending successful completion of a 3-year probationary period. Assessed a civil penalty of $2,000. Sorry, my page skipped. Harold Serrano, EMT 449474, for violation of part 800.15A, 800.3 AM, and 800.3 AL, suspended for 1 year effective 8/20/24. The suspension is stayed pending successful completion of a 3 years probationary period. Assess a civil penalty of $4,000. $2,000 is stayed pending successful probation. And lastly, Amanda UG, EMT 256221, for a violation of part 800.15A, 800.3 AM, and 800.3 AL, suspended for 1 year effective 8/20/24. The suspension is stayed pending successful completion of 3 years probation. Assessed a civil penalty of $4,000. $2,000 is stayed pending successful probation. Outgoing emails included an email to the CMAC, SEMSCO, and the Bureau of EMS leadership requesting closure on cases. Outgoing email to SEMSCO, CMAC, and Bureau of EMS leadership regarding online medical control questions. Email to Nassau County Medical Patrol providing monthly reports, diversion, e-bridge use. And a request to Dr. Jason Winslow from Suffolk County EMS Medical Director to be present at this meeting to discuss best practices and development of online medical control for our region. Moving on to reports. I just want to take a moment to wish those here celebrating tonight's or this upcoming holiday a prosperous, happy, and healthy New Year to you and your family, and for everybody to be safe. So I had spent last night on the phone for about an hour and a half with Director Greenberg with regards to issues in the region, some of which will be discussed under new business. I hate to say it, but there are attacks occurring about me, about others in this committee, behind my backs and in front of me, to county executive leadership, elected leadership, appointed leadership. And I think it's important for this entire committee to be aware that this committee, its members, are protected by state law, so long as we continue to act in good faith. And the reason why we have all discussions done with full transparency in a public meeting is so that everybody has an opportunity to opine. And so that no one individual or faction can consolidate power for use against others. If anyone feels that this is not occurring, then they have a moral and legal obligation to bring those concerns before this committee. Attempting to backdoor and intimidate members of the committee is not only morally reprehensible, but not in the best interest of good patient care or forward progress that we've been trying so hard to sustain in the region. New York State CMAC met, and there'll be a lot of information provided under that report. And lastly, Vital Signs is going to be in Rochester in a week and a half. There's going to be a pre-conference for medical direction by the National Association of EMS Physicians. For those people who want to learn about medical direction, it's strongly encouraged that you attend. Exactly. Okay, so for CMAC, The governor appointed two new position members as Dr. Jeremy Cushman is leaving. His work as a member of the CMAC was also recognized. The Bureau is working on a 2-year full service inspections, and they're going to be making rounds after a complete cycle. They're noticing a lot of things expired that are being found on vehicles. So when you're doing your vehicle 800 checks, please look for expired items. Part 80 inspections or Part 800 inspections, also make sure agencies stay on top of your paperwork. This includes controlled substances. And that if your agency has any questions, you're supposed to call the local district Bureau of EMS chief. Director Greenberg also said that the Bureau of EMS is spending over $4 million. Last year, 1.6 million went out in education grants. And this year, over $2 million is going out in education grants. NEMSIS transition to the new version is going well. Over 95 EMS agencies have transitioned over to the new platform. And just be forewarned that in January 2025, NEMSIS is going to have some minor changes, which may again cause the PCRs to get stuck. So please keep an eye on that. Remember, it's your agency's responsibility to make sure your PCRs get uploaded, not the regions, not the PCR vendor. They mentioned pediatrics and the pediatric readiness survey. Statewide, we did very well. The EMS memorial was held the day after the CMAC. Sadly, 8 names were added to the new memorial. They were all 9/11 victims. There's a lot of regulatory changes that are coming out, signed by the governor. Policy statements also came out regarding vehicle and equipment regulations. Those are going out for public comment, and they'll go out again in November so that the CMAC can vote on them in February. Ambulance and blood regulations were going out and were approved, so please look for that. Our region, based on the RTAC, will not be carrying blood in the ambulances on the ground. Community paramedicine is in a draft form at this point. There's a community paramedicine advisory council being vetted by the state. And they're looking to change regulatory guidelines based on community paramedicine recommendations in the future. There's 2 new policies, 3 new policies, 24-06, 07, and 08 are posted on the Bureau of EMS website. Training and education, I'll leave for you. Under medical standards and protocols, the BLS gel was presented. There was a PowerPoint presentation given by the Western REMAC region. Hudson Valley, thank you. And basically, it demonstrated good efficacy of the program, that EMTs are capable of putting in the supraglottic airway. They're going to try and get it to be a nationwide skill. So then we could take it out of the experimental phase and move it into our usual and customary care. Until that time, the state has said that it's going to remain where it is, that Hudson Valley is going to oversee it until the state takes it over and it becomes a standard of care. Talk about blood. There were New York State Parks has park rangers that provide austere medicine and a series of protocols just for those park rangers providing austere medicine was presented and approved at the CMAC. It needs to be approved by the Commissioner of Health. The New York State Collaborative Protocol changes were submitted and approved, which will again be voted on in their entirety at the next meeting. Lastly, New York City Rescue Medic Protocol changes were brought forward and approved by the CMAC. EMSC or EMS for Children, Dr. Cooper informed us that there are pediatric agitation training videos, not how to agitate your kids, because we all know how to do that, but how to deal with suicidal, autistic, and violent adolescents. And there's different scenarios. So if you're doing training for your agency, please look at those videos. Under old business, there was a medical director, New York State medical director update. So right now they're doing a restructuring in the organization chart at the Bureau of EMS. They are waiting the completion of the org chart before they could post the job. Under new business, there was a discussion about the collaborative protocols. And I'll save my thing to the end. There was a discussion Dr. Doynow brought up under new business, which is really old business. Dr. Doynow is the chairman of the CEMAC, about EMS wait times and wall times in the hospitals. Remember, we addressed this topic during COVID. Please keep an eye. The weekly EMS coordinator report tracks wall time based on the time the ambulance arrives at the facility to the time they go in service. So if you're a health system or a ER leader, please pay attention to that so you can keep track of your department. With regards to my presentation, at the last part of business at the CEMAC, under new business, was a question. Well, there were two parts. There were two questions posed to the CEMAC. One question was regarding clarification of online medical control. And the second one was regarding a quality question. Did you want to play that?
In the sake of time, I mean, I'll defer to you as chair. You want to ask the body.
So,
It's a 40-minute video. If you haven't seen it already, I mean, I see heads nodding.
okay, if you've seen it, the majority of people have seen it, then I'll just summarize it.
You want to start it when you've had enough, we'll stop it.
Summary is good.
The summary is good, okay,
Just
all right, great.
Okay.
All right, so basically, questions were asked regarding, who's in charge of medical control? Who owns the data? What do we do with the data? How do we get the data if there's a quality issue? The part of the discussion I had with Director Greenberg was that, and it was reaffirmed at the medical standards meeting, and then at the CEMAC with the Division of Legal Affairs sitting at the table, also reaffirming the REMAC's job, barring anything else, because the law is very sparse in its clarity, is that the region can credential and subsequently decredential physicians who are providing medical control. That was explicitly stated by the state and affirmed at the meetings. The other thing that they said was, with regards to the quality discussion, the REMAC can explicitly, with good reason, remove an agency medical director because the REMAC is empowered to credential and decredential an agency medical director. In a private conversation last night with Director Greenberg, he said, you guys need to write a policy. So with that, under new business, we're going to bring up online medical control as a discussion issue. Are there any questions regarding my report from CEMAC? Yes.
So much of that discussion and the questions that went on were based on a scenario you presented to them, which was false. You made a claim that you were outright refused information and data, which was false, and that you were directed the only way you could get it was to subpoena an agency, which was false.
So I'd like to address that, but not here.
Yes.
These items were discussed at the QA/QI committee, and to maintain the confidentiality
But I'm
of
just
the.
reviewing what you just put on recorded video there. I'm not talking about any
I
specific.
understand, and there were no agency demographics. There was no hospital demographics. There was no provider demographics provided. It was a neutral statement of fact. And the specifics to which were discussed at the earlier committee meeting. I would ask that you speak to your representative at that committee to find out the discussion. And then that committee asked me to bring forward to the state the statements that I made. I only brought forward issues that I was directed to on behalf of this body. So that's as far as I can get to addressing your comment. Is there any other comments regarding the CMAC report? Okay, so moving on to QAQI, Dr. Zazar.
So Dr. Kugler, I'm sorry, you're saying that what you addressed at the CMAC meeting was brought to CMAC from this committee?
Yes.
That we asked you to address that publicly in CMAC?
Yes.
QAQI, we had a robust meeting, to say the least. Basically, the only thing right now going on is after a discussion, case number 2405, is being brought to the, as a second motion, is being brought to the State Attorney General for clarification. And that's really what came out of our meeting. That will update you at the next QAQI meeting.
business. So QAQI. Case 24.
All plus. Clarification.
Okay, so bring that up under new business.
What I have on my report.
Okay. So that's QAQI, moving down. Airway RFI, Dr. Silver.
So, the Airway RSI committee met last week, I believe it was. We made a couple changes to the RSI program. We're changing, if I should say, some of the requirements to be more, recommendations. Some of the things that we did do, we changed the required 3-year experience to recommended 3-year experience. We've also changed the wording, to be an approved paramedic program. This is done to put us more in line with the current DOH Bureau policies that says a medic is a medic. There's also some wording changes to mutual aiding, that mutual aid will be provided from RSI medics to can be provided. The reason these are all being done is because the medical directors are the ones who are primary in paramedic credentialing for RSI at the individual agencies. And we want the Airway Committee to be a more effective resource that's going to help maintain high standards, but also allow this RSI program to move forward within the county. So we all agree that it's about getting the right people at this point with in the RSI program, as much as it is making sure people have proper credentials. This is gonna come as a second motion, I guess, during new business or old business.
It's new business.
New business, sorry. Other things that were covered, we're getting a whole lot of good data from the eBridge airway form. So much so that we're not quite sure what to do with it all yet. So I believe there was some discussion about having some of the NUMIC, whether it be residents or such, that are looking for research projects or other departments to help go through this and see what we can do to provide training and practice recommendations for everybody. We're looking also at New York City Rescue Medics for reciprocity with regards to RSI training. Whether or not the training that they go through will qualify for the necessity of the difficult airway course. And Suffolk County is offering their airway course as an option for us. And obviously they will recognize our classes when they are starting to be held. As Dr. Kugler mentioned, IGEL was presented by Hudson Valley, and it does show that they were very successful in placement. They had a 10 to 20% ROS rate with BLS IGELs. Whether or not that translated into good hospital outcomes is another story. The new collaborative BLS protocols are going to, in the near future, have BLS IGELs as an if trained and equipped recommendation. As of right now, Hudson Valley has closed registration to new agencies. So basically, if you're in, you're in. If you're not, as of this point, you're going to be waiting for the new collaborative protocols. And then lastly, with regards to voting members, myself and Dr. Gorski were added as voting members in the Airway Committee since we represent RSI agencies. And I was elected as the vice chair of the committee. Questions, concerns, criticisms, complaints, critiques?
Thank you very much. That was great. You guys are always doing great work, so thank you. Moving on to protocols, Dr. Ryan.
No meeting, we've not had an agenda since the last meeting, so we did not meet.
Credentials, there was no requests to be added to the list of field providers, so there's been no meetings, so no report there. Policy, Vermont and Dishner.
Just like Dave mentioned about the error policy, and if there's some policy about control, I guess, if he says you get the language, after you have a discussion for the conversation with Steve earlier.
Okay.
Work on that.
Okay, so we'll stay tuned then. Thank you. Any questions? Okay. RTAC, Don, did they meet?
They did, they're still in the organizational phases, specifically, board was put on their radar. As we continue the conversations regarding TSA and trauma care in the region, TXA, sorry, what did I say, TXA? Man, do I want to get on a flight. Freudian slip. TXA blood on their radar for future discussion and awareness, along with eBridge and the trauma form, which they seem happy with. They don't anticipate the discussion wasn't any action items right now. And then lastly, the open RTAC seat on Remsco, I believe, not REMAC, right? On Remsco, which they're gonna get us a body for.
Great. eBridge. Yeah,
Comstag, there was no meeting in a report.
so I do have some data to just review for the group. The year from last year's use, as I reported last time, was 15,702 notifications made. As of September 26th, there were 37,393 notifications made. In addition, there were 408 video calls year to date. Of the notifications, 627 were trauma notifications, 118 were STEMI notifications, 633 were stroke notifications. And we looked at non-acknowledged cases. 95 notifications came up as not acknowledged, but none of them were critical or red cases. They were the low priority cases, which by regional policy allows to be not acknowledged and be busy. So it's being used widely. There's still plenty of opportunity to be used some more. But I expect its use to just continue to grow and grow. So thank you to everybody that's using it and implementing it.
Bill, can I ask a question?
Yeah.
I don't know how the data is collected or what triggers acknowledged, not acknowledged, but if medical control acknowledges, does that count as acknowledged?
I don't know how the filter's set up. I just,
That is-
eBridge set it up for me, so I just look at the data and I just look at a raw number. I can go dig down and look for you if you like. But I think it looks for hospital acknowledgement. but I'll look at the filter. That's a great question. All right, so the Nassau EMS modernization tag, Chuck, any movement on that? And you know,
Not since, the last meeting when,
Chief
Chief Utara spoke on that, there's been no communications, with the region or anybody they know of as far as a subsequent meeting, regarding the committee, on that, hopefully in the near future.
Okay, thank you. While I have you, would you like to give your Remsco report?
Yeah, thank you, Dr. Kugel. Yeah, from the Remsco side, first of all, we are holding the, 2023 EMS Awards Dinner, on Wednesday, November 20th, 2024 at the Coral House in Baldwin on Milburn Avenue at 7 p.m. from 7 to 11. We've had 10 recipients of awards here in the region. Which I'd like to just read them off. They've all been notified, and once again, letters have been sent out on behalf of the regional council as well as the REMAC and the executive board. For Advanced Life Support Provider 2023, Michael Mena from the Northwell Center for EMS. For EMS Communication Specialist of the Year, Megan Allison, Northwell Center for EMS. The Harriet C. Weber EMS Leadership Award, Mark Vitale, Nassau County Police Department Air Bureau's Fire Department. We had 2 EMS Educators of the Year, 2023, Joshua Golub, the Nassau County EMS Academy, and George Choi from the Nassau County Fire Police EMS Academy. The Registered Professional Nurse of Excellence went to Kristen Keating from North Shore University Hospital in Manhasset. The EMS Agency of the Year was Northwell Center for EMS, and they also once again won the state award for EMS Agency of the Year as well. The Costas T. Lambrew Physician of the Year Award went to Jatinder Singh from Nassau University Medical Center. The Nassau County Remsco Chairman's Award went to Kevin J. O'Hara from the North Merrick Fire Department, as well as, once again, an instructor with Nassau County EMS Academy and the Fire Police Academy, for his dedication and for his 51 years in the EMS system here, as both an instructor and as a clinical provider. And last but not least, went to Nassau County Technology and Innovations in Medical Communications to Chairman David S. Kugler and Dr. Joshua Kugler for that. As I said, there are flyers on the table over there. I'd ask that all agencies as well as the hospitals and stuff take it. You can order tickets for the dinner through the flyer. They're over there. And once again, tickets are $50 each for that. The New York State Program Agency contract has been upgraded for 5 years. We're just waiting on some final details and some financial paperwork to come back from the CPA. All of the financial reports for 23-24 are currently being worked on and should be back within the next week or so. Once that's done, once again, we will be able to execute those contracts and get the reimbursement from the state to forward to the county for their administrative assistance with that. Membership letters for attendance were sent out to members and constituencies within the Remsco Council. We've had a number of constituencies that have failed to maintain, per the bylaws, their attendance at meetings. So therefore, letters were sent out. We've gotten 3 responses back so far out of the 7 that were sent. We're still waiting on some. They were given until November 1st to respond. Otherwise, it'll be brought to the council to determine if those constituencies need to be replaced with that. The council bylaws, as per the bylaws, need to be reviewed every 2 years. Chairman DeBobis of the Legal and Governmental Committee has put together a draft. It was brought out at the last meeting in September of the Remsco Council. And we'll have further discussion on the amendments and recommendations and stuff on that at our November meeting, determining whether, once again, we can move forward or once again, decided at the January meeting with that. Elections will be coming up for the executive board, as I will be once again moving out as of the end of December. So they will be taken care of at the November meeting as well. Also at the last meeting, there was a request once again to determine if the Remsco meetings and stuff might be taken to different times. I will be putting a survey and stuff out there to the Remsco Council to see what comes back with that, with recommendations that maybe they could have some meetings and stuff at night to make sure that we get added attendance and stuff to these meetings. And you know, we are live streaming all of our meetings and stuff now for transparency. So we'll see what that comes back with on that. Last but not least, once again, the MCI committee, Chairman O'Hara once again has been working with the committee on looking to complete the training PowerPoints to be rolled out to the various agencies and organizations that are affected with the emergency management plan that was put together. We've held the seminar in June, got a lot of good feedback from a lot of different providers and stuff, some very good suggestions, and they're once again putting that together. And we hope to have that out to the agencies for agency training in the early part of 2025. The last thing, once again, the next Remsco meeting is scheduled for Wednesday, November 6th, 2:00 here at the PSC Center, all are welcome. And that's all I have. Any questions?
Okay, no questions for the chairman. The next committee is the ED committee. The chair, Dana Portapasso, just had to step out for the holiday preparation, so she asked me to read her report. The committee met last week and talked about best practices regarding diversion. And best practices including throughput optimization, surge planning, early identification of when sites are reaching capacity. This was provoked out of a discussion that was shared from the Rhode Island policy, proposed policy, where they're considering eliminating diversion from their emergency departments. And that diversion would be restricted unless there's imminent risk of injury or harm. And she also then says that they reminded the committee, the members of the committee that were in attendance, about the advanced airway confirmation form on eBridge that the physicians are supposed to acknowledge and attest to. And lastly, she wishes everybody who's celebrating a happy, healthy new year. Any questions I could pass back to Dana?
If you could just, once again, I don't know if she's got it yet, get it out, the flyer and stuff, if we could just get that to the administrations of the various regional hospitals as well as the EDs and stuff, to once again honor all of our recipients for the awards.
Okay. I'll text her now, please share. All right, so that was ED committee, EMS coordinator. That's it.
Progress.
Okay. That's a nice fast report. Unfinished business. Thank you. All right, any old business besides the bridge that was mentioned? Okay, new business. I would like to recognize again our guest, Dr. Jason Winslow, the medical director from, Ernie.
You have 2 items listed as unfinished business here.
Yeah, the eBridge updates.
Quality issues in online medical. And they all, was that from last
I'm
time?
you know what, I'm looking at my notes instead of the agenda, I'm sorry. Thank you for calling me out on that. Let me just see. So the quality issues were discussed under quality. And under new business, the quality committee is asked for items to be brought forward. And then for online medical control, again, that's gonna be discussed under new business. I'm moving to new business. So thank you, for bringing that to my attention. So speaking of online medical control and old business, again, Dr. Winslow is gracious enough to join us. To share with us best practice from Suffolk County, our neighboring region. As to how they do online medical control, how they do quality for the region. Understanding that their region is very different than ours, with medicine is medicine. And so maybe we could learn a little bit about how to improve what we do. Floor is yours.
Thank you. So yes, each region's medical control is determined by each regional REMAC. So you have the duty and responsibility to decide as a group how you want to do medical control in your region. What we've done in Suffolk, and I've been on Suffolk REMAC for 24 years, serving as its chair or vice chair for 10 of those years before taking my current role as the regional medical director. We decided one centralized medical control for the 109 separate EMS agencies in the county. Currently, that is under contract with the Department of Health with Stony Brook University. The contract has been in place for 12 years, works well. The county owns the contract. The contract includes the data. So the county owns the data that is brought to us by our contracted vendor, which happens to be our largest trauma center, our largest hospital. And they use their staff, paramedic supervisors and physicians to man the medical control. We also use it as a quality improvement tool. I have the medical control supervisors doing data metrics for me. They'll call me in real time or text me if there's a esophageal intubation, if there's any significant issue of a hospital's request for diversion. We use the medical control for that as well. And we also get data metrics on cardiac arrest. So we have a policy in REMAC and Suffolk County's REMAC that you have to let medical control know after the call if there's a cardiac arrest. So the medical control operator can contact the hospital to get the outcome data. It's usually done 7 days later, so we know if the patient survived, did they survive ICU admission, did they survive the hospital discharge, etc. And then I get a monthly report. These are the advanced airways, these are the cardiac arrests. I have to track behavioral emergency cases where chemical restraint was administered. I can change it as the contract owner if I want them to do more work or less work, and it works quite well. What I will tell you is it's a resource 24/7, 365 for providers of all levels. Just to bounce an idea off of the paramedic supervisor who sits there. Hey, I have this wacky call. This is the protocol I think I should be in. What do you think? Or, hey, I need a doc on the line. I have no idea what I'm doing. And so it becomes a resource. It's used approximately 20,000 times per year. And our annual call volume is 180,000 calls a year. That was the short version, but I thought it might be easier to just ask the REMAC if they had questions about it as you think about your region's medical control and what policy you will either adjust, amend, or create. We've had a policy in place for many years. It's on our website. You can read it. It's policy 1 because that's how important medical control is.
Is there a financial?
$0. Going out to RFP in 2016, and at the time, the 3 competing health centers all put in bids and it went out for the lowest bid.
Are there any standards or requirements for the people who are answering the phone and?
Yeah, so as the contract, as the health department, technically it's the commissioner of health, but Dr. Biggett has authorized me to take that lead as a EMS physician. I am allowed to determine who is allowed to be the supervisor and what their credentials are, although we don't pay them, they are paid by Stony Brook. Same with the physicians. So currently all the EMS double board physicians take medical control consults, and physicians who've been in service for more than 10 years. They also allow their third-year residents to do supervised medical control calls as a learning tool. But they have 6 EMS double boarding physicians who take most of the calls.
How about in the communication part of it?
Yeah, so they technically are selected by Stony Brook, but we have the ability to authorize, if you will, who it is.
Thank you.
It's the same setup.
But is there like a certification that you bestow on these people that they are medical control qualified? Or something?
Most of them have been in service more than 20 years.
But the paramedics,
Yes, all of them.
as opposed to CCs?
We don't have any CCs on medical control. Please don't bring up the CC issue. That's a gone issue.
I understand. Well, it's almost done.
Did anyone have any questions? I know I kind of gave you the short version.
Question.
Yeah.
If you have a QA case, just, we had, so we're trying to figure out. And we need to play the video or recording, how does that process work in something?
So it depends on what it is, but we also control all the dispatch data through the CAD, so that also falls into my medical oversight. So if you want to know is how long did it take for an ambulance to get to my mom when she had a heart attack, I know. And how I share that back with the agency is I call the medical director, and we have a closed door meeting, and I really guide my doctor. I do the same with a medical control consult. Sometimes a paramedic or a user of the system will complain that they got a less than stellar consult. I then have them send me the recording. I then call the physician, have a conversation, and then I call the agency medical director of that agency and connect the dots.
Because you have access. 'cause you
I have
contract-
access, yes.
Contract specifically from, to have access.
Yeah, the contract clearly states that the data is operated by a contracted vendor, but owned by our contract, which is us. It works well, and I take it to the physician level so that it's all not discoverable. What we talk about in QI is discoverable to anyone. Close the door and we have a discussion, and you go figure out what you're gonna do with the information I gave you. At the end of the day, the care that you give only changes if you're looking at the care that you give. And we get most of our queries about medical control on the paramedic advocate end, where they think that they got a bad consult. So I do have to do a little. I shouldn't say, I should be careful how I word this. I do listen to the exact recordings, and sometimes I have to make a phone call to call the physician and say, what were you thinking? That's not the usual. Usually it's that the paramedic didn't give the information for the consultant medical control physician to give good information back to them. But I can listen to both ends of the conversation, and I can actually even call the provider. I usually don't do that. It's unusual. The other thing we use it for, though, is sometimes transport decision making. Like we talk about diversion, we have a diversion policy authorized by REMAC, which under Article 30, the transport of patients is by the REMAC. So you guys decide if you want to do diversion or not, how you want to do it. It's not a county issue, it's a REMAC issue. What I will tell you is having no diversion is really good, because we only do it for physical plant disruption of the facility. Now, I happen to work in one of the hospitals that was a repeat offender at 10, 15 years ago, always requested to go on diversion because of overcrowding. So it's typically specifically states in the policy that we wrote is you can't use it for ED crowding. Because what happens is everyone's on diversion at the same time, especially with the way the hospitals connect to one another. So for a physical plant issue, you have a lone shooter in the emergency department, like happened at one of our hospitals, we put them on diversion. But they don't request, we put them on diversion. And it's a 4-hour process until it wears off, and then we decide, are we gonna do it again? That's done through our office. So just be careful with requesting diversion based on crowding, because it doesn't work that well. I think that you're gonna see that when you look at other systems. It works well when you can protect that patient from a physical plant issue. Another common scenario is the cath lab computers have to be rebooted, so they can't be on STEMI notification for a 12-hour period. So they put themselves as a request to diversion. We honor that because we don't want a STEMI to go to the cath lab if their patient's gonna have to be transferred.
Yeah. So do you have a physician, staffed in medical control at all times, or once
They
again,
use
are
their,
they on?
they use their phones, so the six EMS physicians all take turns with their phone to be able to work or be at home or at a restaurant.
So they're in the ER, but they're accessible,
Correct.
as needed, by the medics.
Yeah, they usually do them by 24 hours, so one of them will take like a whole day, because they have six.
And there's compensation for those doctors, or is it part of their contract with the hospital?
We do not get involved with their own personal contracts. That's up to them. We pay them nothing. So that's the answer.
Solely proposed, they're still.
Yeah.
Solely.
Yeah. Most of the EMS positions there are more senior positions who may have some protected time, but that's up to them.
Any other questions for Dr. Winslow? That was great. There was a lot of,
Thank you.
questions answered just by your presentation. And I'm grateful to you for coming and spending your afternoon, having to go through traffic to come here.
Not at all.
So thank you. Just so we could let Dr. Winslow go, are there any other questions for him before we continue?
Or if anybody wanted to just email or call me after, they're welcome to do so. I'm at your service. I'll leave my contact information with Don Whitson.
Yeah, perfect.
Just don't call him for orders from somebody's living room.
Just like curious, how often do you do the RFP, for that service?
We just, the RFP was done in 2017 was the last time, and we're currently still in the contract period. So I don't know the answer to your question.
Okay.
That's more of a legal question than
Maybe 10 years.
And that's negotiated between the county and health department. Agency that, yes.
So the contract is with the county of Suffolk, and it went to health, even though it's also public safety. It's the county of Suffolk, and it's administrated by the Commissioner of Health. And I'm the designee for the Commissioner of Health. But you don't want to get into contracts. Anything with a lawyer is a mistake. So I just tell you, I'm gonna put my little medical director hat on for a second. It's about patient care. If it affects the way you take care of a patient, you do it here and you make a policy, let the lawyers fight about it later. That's my,
Okay.
Anything else, Dr. Winslow? Well, thank you so much.
thanks.
Yeah,
I do want to make
Yeah.
one RSI comment. If it's okay,
Please.
maybe I'm allowed to speak.
You're the
as a
guest,
member
you
of
can
the
do whatever you
public?
want.
So we've had RSI since 2009. The original credential was that the RSI subcommittee credentialed the providers who had 10 field tubes and 5 years of service. After 10 years of doing that successfully, we decided to look at 3 years. And that went well. We still had the 10-year tubes, 10 field tubes requirement and a 3-year commitment. But during COVID, a couple of providers from a couple of agencies asked the RSI subcommittee for a waiver of the 3-year period, and they have been not as successful. So I'll be cautious of agency medical directors who wish to bring in a paramedic to use RSI under your medical authority in a setting where they aren't a rock star. It's for the rock star medics in your agency. And if you think someone with less than 3 years of field experience is a rock star, I beg to differ. It also depends on how many years were they in EMT before they got their medic. The old way of doing it, you had to be an EMT for 3 years before you could take a medic. Now you don't. So you might have someone who has no field experience. They came out of medic school. And now you want to put them into do RSI. I wouldn't make that mistake. But I will tell you, it's a great program when you have the agency medical director involved, and that's the way it works. So I recommend the agency medical directors doing this. Please to continue to take care of the program, take care of the medics who are doing it, and address any issues in real time as they come up, because you don't want to be surprised at the end of the day. All right. I know you're discussing that under your motion to consider 3 years as opposed to require. So I just give you my information. You can take it and do what you want with it.
Thank you.
Thanks. If anyone else has any questions, they want to call me or email me, I'll leave my information with Don Benson.
Thanks, Dr. Woodway.
Thanks.
Thank you.
Have a good year.
That was great. So moving on to other new business,
And you can just
sent to the ED committee, which was brought out in her report, was that document regarding removal of ED diversion, except for emergency situations, sort of like what Dr. Winslow mentioned. I think we need to get buy-in from the ED committee first before we sort of move on to here, even though it does come from this body. We need all the, I think all parties involved need to sort of have a say in it. But I would like to ask that we can keep this on the forefront as a new, as actually will become an old business item for discussion, so that we can act on it when the ED committee brings forward their recommendations. Is that okay?
I have a question for clarification. So what I heard Dr. Winslow say is that the ED does not initiate the diversion. It's actually done by the online medical control.
Correct.
So I know, respect that, I want to hear what the ED committee has to say, but I think as a body, we need to sort of have a position as to whether or not we're going to follow the same lead as Suffolk County, where it's driven by online medical control and not by the ED. I'm sure they're gonna have their opinions and interesting comments, but I think the biggest question is, are we gonna go with a structural failure? How does that information get relayed? And who makes the decision inevitably? Is it gonna be one or the other? And I think we should be firm, again, about who is making the decision.
The decision is always medical control. Hospital can ask for diversion and they're gonna be told, no, there's too many hospitals.
So, and that's where over the years, I agree with you, and that's traditionally from what we understand here in this body, but what does the hospital, assume? They assume when they've called medical control, and I know it's been misconstrued over the years.
We also have an issue too with some of the hospitals that are on the border with the city. City has different rules. They get different timeframes, they can do different things. They assume when they call one that it works for both, and it does not. So an education on their part would help in a lot of the communicate, well, I wouldn't say miscommunication, the misunderstandings they have of what they can get.
Yeah, and I just want to comment, and I'm sorry, Jim.
Sure, sure.
So, exactly, so I think education is critical, because I know I was the person to run down and said, look, you called for it, but they haven't issued it. You have to wait for their correspondence back to you that they're gonna issue the diversion.
A physical plant failure or fire or a public safety threat is a completely different animal, and I would hazard to call it a diversion. We do that now. It's a closure. It's a hard closure. Our EMD supervisors are out in the field. They assess the situation. We're gonna know about it. We have a discussion. Sometimes we don't need to have a discussion. Obviously, if you're on fire, we don't need to have a discussion at that point in time. We have a discussion with the ED administration, and then based on that discussion, we'll close you. And the difference being that if you have an unstable airway or an unmanageable patient and you're on diversion, technically, by policy, you can still have a patient transported there. But when you're closed to all receiving ambulances. That's it.
But there is some subtlety, right? So that's something that's very, obviously obvious, fire, but if there's we need to reboot the cath lab.
Those are stratified
We
particular
also have,
issues that we also.
the body has made it possible that you can go on diversion for specific things, like, all right, just your Catholic is closed, you're not on diversion, just your OB is closed, your psych is closed, whatever it's gonna be. Do you guys have, the rules you've set forth are very intricate and they're very specific. We don't allow neighboring hospitals or same catchment area hospitals to be on diversion at the same time. What he referred to as diversion for, whatever we call redirection, whereas you may not want to go on, your administration may forbid you from going on diversion, but you're 7 ambulances out the door and an hour and a half to get triage. We will put you on redirection just to decompress you and try to take some of the weight off.
Provided that the neighboring hospitals are in the same condition. If that's the case, which we've discussed here previously, then nobody gets it. But it's a very dynamic thing that the EAB supervisors are actively assessing dynamic on a daily basis, on an hourly basis.
Sorry, Jim.
Oh, yeah, no, I was just saying, it's a very collegial conversation, and actually, it's not, it's not like they wait, I mean, they noticed and they put you on diversion. As you know, I worked in Suffolk County for the last 10 years, and when we call in, we see our CAT scans down, and I say, okay, we'll put you on stroke diversion, or well, what do you need diversion for?
It's a same, it's
So,
it's on
yeah.
stuff again.
Right,
It's the same.
so
We're
it's pretty
quality.
straightforward out
I have no
there, I
problem
mean, it's not
saying
like
no.
they've ever said no when we have a facility issue.
Ernie?
So I'm still a little bit confused, I'm sorry. Who exactly is medical control? Dr. Winslow said he was the medical control. He's making the decisions and stuff like that. You get medical control from your physicians. Is it physicians or the medical communicate? Are they medical control or are they medical?
I think what he said, if I heard him correctly, is that while he has oversight, that contract is held and borne by Stony Brook University, where they render the contract for medical control. So they implement, he just does the quality control and oversight of it. I think that's what I heard him say.
And there are 6 physicians there that take the rotation, so.
Just in speaking to Dr. Winslow about this upstate, Dr. Kugler and everything, my interpretation is that, and again, there's some Suffolk providers in here. Diversion in Suffolk is not the norm, it's the exception, and specifically not for overcrowding. I think my interpretation,
We don't see diversion in Suffolk. I mean,
yeah,
psych is a whole separate issue because that doesn't go through EMS a lot of times. It goes through non-EMS agencies. They're brought in by the police rather than EMS. But there is really no diversion short of facility failure.
yeah, I think Chris is right, we need to really hammer out within our own profession what we mean by certain terms. I agree, when the place is on fire, they're closed, they don't exist. Versus diversion, where that means different things to different people in different regions, so.
Your CT is down. Is it for planned maintenance? Is it for unplanned maintenance? What's the time frame? These are all very.
Well, and, yeah, right, are you closed to stroke? Which I agree, I think that's what we're all talking about, versus reverting stroke, where now you could have one show up there, and that does nobody, especially the patient, any good. So,
Yeah,
so the thought.
So again, the only reason I brought it forward is there's obviously a lot of nuance. So the ED committee, I think, should feed in what their thoughts are, but in fact, we have to make a decision as to how we define it. Is redirection still gonna be viable? Are we going on diversion only for structural failure or inability to safely care for patients? And volume not being one of the drivers. Because right now, it sounds like volume may be a driver.
I think the initial
The
question,
majority of our requests and whatnot are volume.
Of volume, and so you're gonna get a very, again, I think there's many people here that have the same experience I do. That, I think, is what's gonna come out of that ED level committee. Obviously, if they're on fire, they're on fire. Obviously, if their CAT scan blows up, those are pretty black and white scenarios. So I just think we as a body need to start thinking ahead of that and saying, what do we consider, diversion, for? What the real reason? Sounds like Suffolk already did that work.
And I actually agree with a lot of that, because the less people that are able to call for diversion, I'll give you my example. When I was first there as chairman at St. Joe's, a lot of different people could call for diversion, and you would get all kinds of, I hear about, well, call for what? What happened? And we've taken it away so that I'm the only one that can approve it. And it doesn't happen as often as it used to, somebody has to call and then you have to go through numbers, but, it's happened. There's multiple, counties that have gone, or now outside of New York that have gone to, there's no diversion. So unless there's something like this, so.
And also understand that whatever rules you pass, there are people that won't gain it. So. Not a comment on just that it exists as the dashboard with a time. And the neighboring hospitals know exactly when they're supposed to come off, and will preempt a call to be next. So we'll say, oh, you can't go on until they come off. 15 minutes before they're supposed to come off, they will call and say, we're next, but it's anybody. So, there's gamesmanship.
So I would say that maybe the policy committee and ED committee need to meet and then come back to us with recommendations.
I'd also like to put out there, though, that
Yeah.
as much as he says there is no diversion. If we're sending our patients to somewhere where they're gonna lay in a hallway for 4 hours, I mean, who are we serving? If we're serving our patients, and it's their best interest that not go there.
Right.
So. I understand the hard line, I get it. They have a different geographical layout in Suffolk County as far as the next closest hospital. Where here, we're pretty gifted in how many we have. So you guys have to strike that balance. In what's patient's best interest.
Oh, thank you.
Recognizing that there's also not necessarily an equitable patient distribution and subsequent resources that are getting absorbed. So my shop might get patients that have different resource requirements than are going to other hospitals. We might be overwhelmed with behavioral patients in our medical ED where many of the hospitals in the area wouldn't be, creating an unsafe environment. It's not a physical plant problem. That's a volume problem that we are the only hospital that has and can't contain it. So that needs to be addressed as well.
Just a comment, that hasn't been solved in Suffolk either, because a lot of the, when the CPAP unit goes on diversion, there's only one or two other psych units. That receive, us being one of them, and we get overwhelmed, it gets, but once
I'm
again,
not
but
talking about psychiatric patients,
oh, I'm sorry, I thought you were talking about,
behavioral patients that are brought medically.
okay,
We may have a psych unit, so psychiatry might be a
got it, okay,
term that's being thrown about, but the patient hasn't displayed any psychiatric issues.
Okay.
It's either intoxication or a medical issue.
got it, okay, I thought you were talking about different issue, because that hasn't been solved on.
Sure, yeah, and I understand that, psych to psych, or psych.
So hearing all that, my recommendation would be to have the ED committee feed in, have the policy committee meet separately, not together. Not to conjoin them, but to separate them so that we can have independent thoughts about the way it should look, because I think there's gonna be some different thinking depending on which side of the fence you're sitting on.
They have to eventually come together.
Eventually, that's what the body is for. We'll help them come together to feed all their information in.
So there's gonna be a couple of things for policy coming. You guys have some homework. So, do you want to make a motion on that or just?
Sure, I'd be happy to make a motion based on what Dr. Winslow presented. It sounds like, Nassau County, and I guess it's a segue to the next item on the agenda. Should have the ED committee meet to determine what they believe is best practice for diversion. In addition, I think the policy committee needs to sit and meet and look at what we have currently in writing for the policy on diversion. Look at the terms and the definitions.
Okay, I have to go type this, so you can't go so fast.
I'll repeat it. You can also go to the recording. And then we need to adjudicate or use that information to make the best possible diversion policy that is functional. Maybe not identical to Suffolk, but it sounds like akin to Suffolk, which sounds like it's been working pretty effectively, so that there's no confusion as to what diversion is. That's my motion.
So just to reiterate, your motion is to request that the ED committee meet to determine best practices for diversion. Policy committee to meet to look at diversion policy and definitions and clarify diversion policy.
Fair enough. 75.
Okay, second it. For the motion, because that's okay. Okay, all in favor? Anybody opposed? Anybody abstain? All right, thank you for that. Moving on to the next order of new business. Is medical control. Having looked at the western region. Suffolk, listening to Dr. Winslow's discussion about medical control, we need to create policies on medical control. So I don't know if that needs to be like a motion, or if it just needs to go to policy to create the policy for medical control and then bring it to this committee for a vote. But you're gonna need help. And so I would ask the people that are most vested in medical control, please assist the policy committee So why don't you reach out to Don, he'll coordinate you with all the constituents that touch medical control. And this way you guys can come together and take a look at what exists nearby. Meeting with the colleagues at this table and come up with a policy that's comprehensive, that includes quality, data ownership, reporting, and all the things that we discussed at this meeting. Does that sound reasonable? Okay, yeah, Chuck.
Would a technical advisory group and stuff prior to taking it to policy and procedures be something that, once again, you could craft with all the various
That would
stakeholders?
That would take the work off of policy. So does that sound unreasonable to create a tag?
Putting a tag together and stuff to research.
Yeah, I think it's specific enough to get a tag together. I agree
Okay.
with that. We have experts on
I
it.
bring it to them to, once again, hammer out the details and stuff on that might be
And so
advisable.
there's a motion. Create best practice. And
Maybe have somebody else to make the motion on that.
make the motion, but somebody needs to second it. And then we'll need to vote that. Motion to create best practice tag for online medical control and then. I'll select it out. All right, so I need a second. Dr. Ting.
Can
you
second it?
I
Yeah.
have a question about
A
this.
question on the motion?
I
Okay.
have a question about medical control. I think in Nassau County, we have more than one medical control, right? Well, has a medical control
Yeah.
too, so the policy.
So Hudson
will-
has one.
Yeah, so the policy that
Hunter ambulance has
you're
one.
talking about apply to all medical control.
Well, right now, we're
That's my
we're gonna
question.
create a tag to look at medical control and policy. And then we could address that part of the question within the tag. I can't address it here because we haven't gotten so far as even creating a tag to look at. Yeah.
I would just say private ambulance, even in Suffolk, like Hunter or GMR, their medical control, even if you're calling from Suffolk, is separate from Suffolk's medical control, correct? I think,
Even in New York City,
yeah. So
there are
they have,
10 different medical controls.
yeah,
So, again, that's for the tag. So does that answer your question? On the motion?
Yes, if
Okay.
if you're just looking at the whole region
We're-
and the entire.
I think that's something for the tag to look at. Okay, so yes,
Just noticing, I mean, obviously, there's one big difference. In that Suffolk has a full-time medical director, at least someone who's paid to be a full-time medical director. You know, a lot of areas, jurisdictions have that. I'm not sure where that would be kicked up to, but it certainly
it comes
seems
to
like
this body.
a county like
me.
ours should have.
So that, right now, there's a motion on the floor for the
Sorry.
creating of the tag.
Okay, sorry.
It's okay. So I'm sorry, I don't mean to cut you off,
Okay.
but I'd like to make sure that we get the motion seconded.
Oh, sorry, I'll
I
second.
think we second.
Okay, Dr. Ryan. Okay, so all in favor of a motion to create a best practice tag for online medical control? Okay, all opposed? Anybody abstain? Okay, that passes. So we're gonna create a medical control tag. And then to answer your question, right now, as has been going on for the past bazillion years, it feels like it's all the quality issues that need immediately be addressed are go to the REMSCO appointed medical director for the region. That's in our regional policy and procedure, and that's me.
Right.
It happens to be the chairman of the REMAC. Before me, it was Josh. When we did the controlled substances, he helped implement the controlled substance stuff. And now whoever's the chairman, basically, until there's a pay line. Right now, I do it for free.
Right, no, I understand, but who would be petitioned to make that happen? Because it's,
I don't know.
I'm sorry to interrupt, but for Dr. Winslow, Suffolk County Medical Control, I understand he's the medical director for Suffolk County Medical Control. We do have a medical director for Nassau County Medical Control.
Right, but that's not
It's
medical
not-
director.
Region,
That's,
Nassau Regional, right?
he's regional.
Yeah,
He's-
Oh, he's regional.
right.
Okay.
He is the Suffolk County Medical Director. He's,
Under
but Suffolk
REMAC.
County has,
Under REMAC.
Public structure.
in New York State statute,
Right.
just to clarify, New York
Mhm.
State statute has carved out Suffolk County as its own region and has its own separate set of laws, separate from 16 other regions in New York State. The reason why I say 16 is because New York City also has a carve out. So of the other 16 REMACs and regions, we fall into those. And our region has in its bylaws and regional policy that the REMSCO, which is in accordance with Article 30, has appointed the chairman of this body to be the regional medical director.
If it helps you sleep better at night, Dr. Ryan, that was one of the recommendations in the county EMS.
And that
report.
page.
Maybe someday somebody will read that and become aware of that.
So
We just send a, I think, a letter to
Thank
somebody
you.
and say, by the
We're
way.
trying.
I just want to move
I
on to
know.
new business and we can get to this further discussions. All right, so the QAQI committee is bringing forth under new business a motion to bring case 24-05 to the New York State Attorney General for clarification and assistance.
Correct.
Okay, that comes as a seconded motion from the committee. Okay, so all in favor for this motion to go to the Attorney General?
What does that mean exactly?
Yeah.
Like,
So there was a quality issue, Dr. Sutherland?
Yeah, the quality issue that we're not able to resolve at the QAQI level here.
okay,
We need more information and legal clarification, and it's been brought up to the state level, so the state attorney general has to give legal clarification on that.
okay.
I don't know what it is either.
Oh, no,
That's why we're doing that, yeah, that's.
Okay,
That's why it has a number, not a name.
Then adjudicated.
Right.
Right, we're giving the number just to
Okay.
keep all the demographics.
Got it.
Right.
Okay.
Okay, so any more questions on the motion? Right, so again, all in favor? 2, 3, 4, 5. Okay, so sorry, anybody against? Abstain. Okay, so one against.
I'm abstaining because I'm not sure I understand.
Okay.
The levels of legal,
And then
all the way up.
You
to-
abstain?
Or I
Understand whatever,
Dave,
yeah.
you're abstaining. Okay, so there's 2 abstentions. Okay, so that passes. There were 5 for, 1 against.
I'm sorry. I think there was a question for a clarification. Some clarification.
I have to have some, my own beyond here to understand.
So, I would say that
You
just,
can definitely clarify it for me, but of course I individually.
Can I take a stab at this?
I would,
I take a stab at this.
You need to
I
explain
think she
it.
needs to abstain. That's
Okay.
all I can say.
No, I'm not.
That's all I can say is,
Okay.
based on New York State, public officer
I'm suggesting she should
ethics,
abstain.
ethics and code of regulations, Dr. Barrios has to abstain from the vote.
Was that the question, whether you
So-
abstain, or you had a question as to why it's getting bumped up to the state?
No, my question was, right now at this level, I don't understand the reason for this motion, and I mean, I
So I would ask that,
understand.
because it's coming out of
For my own knowledge.
because it's coming out of a
Why,
confidential committee.
are there any other resources or information that the state has now advised as to the specific case? It's still open.
I would
And-
ask that because this is a confidential matter, that you have a private conversation with Dr. Zaza, the chairman of the QAQI committee. Because this can't be discussed at a public meeting. So, all right, that motion passes. Then there's another motion comes as a seconded motion from the Airway Committee to approve the regional policy changes regarding airway, the changes in terms of nomenclature and a couple of tweaks as presented by Dr. Silver. This comes in second. All in favor?
Those are attached.
Yeah, they're attached to the,
On the question?
yeah, sure.
You had a recommendation, just before you vote on it, you had a recommendation with regard to one of the proposed changes. And Dr. Winslow, who's had an ongoing program, where there's a change in that language to go from a 3-year requirement to a recommended 3 years. And I'm just asking the physicians whether they want to vote for that or not vote for that as a whole. That's all, that's my only question.
So coming out of that meeting, it was down to the discussion that in the end, the individual medical director as the one giving those privileges is the one making that decision. So the discussion was instead of the Suffolk, which he says their board is the one who gives that credential. The discussion that we had, and anyone here can correct me if I'm wrong, is that in the end, the board or the airway committee is making a recommendation to that medical director who has to come to the meeting, present their paramedic, explain why they want them. The recommendation is then made by the airway committee as to this person should or should not, in their opinion, be given those privileges. And then the medical director will then likely want to go with the RSI committee, then go against the people who are setting up those protocols. I'm not sure if I misspoke on that, but that's.
I wasn't there, sorry.
Okay, there's a couple people in the room that were, I'm not sure if I misspoke on that, but.
Ultimately, the responsibility of the committee to decide whether the medical director has given enough information or in support of this person. So it's ultimately.
Okay, yeah. Are there any, does that answer your question?
Yes, it does.
Any other questions on the motion? Okay, so all in favor of the proposed changes? Thank you. Anybody against? Was there, did I see a hand against? No. All right, anybody abstain? Okay, great, so that passes. Is there any other new business for the committee?
I just want to clarify my last vote regarding the, going to Attorney General. I think
You
because of my
voted against.
position, I should be abstained.
Oh, okay, so you make it. Okay, thank you. And then. Okay. Thank you for clarifying. I'll change it. So that makes it 5-4-0 against and 3 abstain. Okay, any other new business or clarifications? Anything for the good of the order? The next meeting for National County, yeah, sorry, yeah.
So confidential, I understand, I'm not going to discuss any details, and you made a motion to send this to the Attorney General. I would suggest for the body that you make sure of what you're basing that on is accurate, so you don't get embarrassed when you do that. All I'm going to say. Make sure what you're claiming is actually the case. So I understand what you're looking for, and you're basing that on either you were given bad information or you knowingly have bad information but don't care. So
Just I have a go to the order comment based on it. I think everybody in this meeting needs to understand this is a public meeting, number one. This is not a time to air things. We need to follow the procedures and the rules that are set forth by the state, how we act. So if a committee, a confidential committee has made a determination, we're here to either support it or reject it. We're not here to have discussions about it.
Or make threats.
We're not a threat. Being embarrassed is
Guys,
on all of
guys,
us.
inquiry is fine. We just need to be collegial and have good discussion. But I do think we have to follow the rules that we need to follow. We can't deviate from that. So I think, you know, whatever your personal decisions are, that's great. Those, if it's a quality thing, it's handled at the Quality Assurance Committee. If it's gonna be something about medical direction, it's gonna be handled at the TAG, and those recommendations can be brought to us and we can then talk about it. Certain things are not for our purview. I don't know the details about the case that's getting bumped up. I don't need to know. I just need to know whether I'm gonna support or not support the quality assurance chair who's saying they can't adjudicate something. They need to go to the next level. So again, just for good order and discipline, I think inquiry is important. We should all be able to listen to other people's positions, but we need to stay within the confines of what we're supposed to be doing as a body. So,
Any other comments or questions? Okay, so the next meeting is Wednesday, December 11th.
I apologize, Dr. Cooper, I apologize.
Yes.
Dr. Singh did not vote.
Yeah, I think I probably missed that.
He missed the vote. I don't know.
I'm also going to abstain for now, till I figure out what's going on.
Okay, so it's 4 abstentions. All right, thank you for clarity. Next meeting is Wednesday, December 11th. It's the second Wednesday of December, not the first, due to conflict with this New York State CMAC. I need a motion to adjourn, please. Gazo, Wheeler. Okay. Thank you very much, everybody. For those that are celebrating, happy, healthy New Year.
I need to stay away. Some of the noise, it's gonna, I mean.